Welcome to Compass Opioid Stewardship in Practice. Each week, our Compass coaches will explore a real-world case, define a clinical goal, and walk through practical strategies to improve care. Whether you're tuning in via video, audio, or reading the summary, this session is built for busy clinicians like you. Enjoy the show.
Hi, my name is Rachel Duncan, and I'm a clinical pharmacist and coach in the Compass Opioid Stewardship Program. This week's case is part 3 of a series on a patient with chronic pain on chronic opioid therapy. I'll start with a quick reminder of our patient case. Mary is a 67-year-old female with chronic pain from past back and spine injury, which is now non-surgical, and peripheral neuropathy from her type 2 diabetes. She also struggles with long-standing depression, anxiety, and insomnia. She is obese with a BMI of 37. Her medications include sitagliptin and insulin for her diabetes, citalopram for depression, alprazolam 0.5 milligram tablets, which she can use up to once daily for anxiety and insomnia, and gabapentin and lidocaine patches for pain. For severe pain, she uses oxycodone 30 milligrams 5 times daily and is prescribed 140 tablets every 28 days. In part 1, we used Mary's case to discuss specific risk management strategies for patients on long-term opioid therapy who have increasing risk factors for respiratory depression and accidental overdose. In part 2, we explored adjustments to her current medication regimen to optimize her risk-benefit ratio. In part 3, we will focus in on how we would rotate Mary from her current opioid therapy over to buprenorphine. In addition to lowering Mary's risk of respiratory depression and accidental overdose, switching her from her current oxycodone 30 milligrams 5 times daily, which is an MME of 225, over to buprenorphine may also benefit Mary by 1. Better treating her neuropathic pain, 2. Improving her insomnia with a lower likelihood of sleep disturbances, and 3. Improving her depression and mood. Also, with a better safety profile, you will now have the flexibility of titrating up her buprenorphine dose to increase the effectiveness, something that you don't currently feel comfortable doing with her oxycodone agent. So to start switching her over from oxycodone to buprenorphine, let's keep the following things in mind. We estimate a 30-to-1 conversion ratio, where 1 milligram of buprenorphine is roughly equivalent to 30 milligrams of morphine, meaning this patient would require approximately around 7 to 8 milligrams of sublingual buprenorphine daily with their 225 MME regimen. For pain management, multiple daily doses of buprenorphine are essential. When treating an opioid use disorder, once daily dosing is sufficient to suppress cravings, but buprenorphine works best in frequent doses for pain control. For this patient, we would recommend somewhere around 2 milligrams 4 times daily using Suboxone films. The patient could also use Subutex tablets if preferred, but the films tend to be easier when making small dosing adjustments during the conversion period because you can easily cut them into half films. And then in this case, a reminder here, we are using Suboxone off-label as the patient's MME of 225 is higher than what is recommended for starting agents like Butrans or Belbuca, which are labeled for pain. So let's review a standard rotation protocol. Starting with day 0, the pre-transition. We begin by discontinuing her oxycodone that evening. Short-acting opioids are discontinued at least 12 hours prior to buprenorphine start. This sets the stage for withdrawal to begin overnight, which is necessary for safe buprenorphine initiation when using a standard approach. On day 1, we'll have initiation. The key here is timing. We wait until the patient is in moderate to severe withdrawal, typically at least 12 hours after their last oxycodone dose. They can self-assess using the Subjective Opioid Withdrawal Scale, or SOWS. Once withdrawal is confirmed, we start low with 2 milligrams of buprenorphine. If symptoms persist after an hour, they can take another 1 to 2 milligrams, so a half or full film, repeating as needed, up to 6 milligrams or 3 films total for day 1. Day 2 is all about stabilization. On waking, the patient can take the total dose they needed on day 1. If symptoms flare, they can add up to 2 more milligrams that day, with a maximum of 8 milligrams for day 2. This helps us fine tune symptom control while avoiding over medication. And then day 3 leads to more structured dosing. Now we split the day 2 dose into 4 doses of 2 milligrams each to maintain steady coverage. The patient should call the office to report how they're feeling and how the dosing is working. Based on that feedback, the clinical team may adjust the plan. We have included the detailed transition plan within the summary of this session. And then a note on supportive care. Ask the patient what symptoms they usually experience when they miss a dose or are late taking their oxycodone, and anticipate those types of symptoms occurring. You can prescribe something like ondansetron for nausea and vomiting and any other symptomatic treatments that may be indicated based on their patient-specific withdrawal symptoms. The Compass OPSS program provides clinical protocols, dosing calculation support through our pharmacists, and patient education tools to help guide transitions just like this. For personalized technical assistance, reach out to your clinical coach to schedule a coaching session. Let's end with the clinical pearls we want you to remember, which are a buprenorphine conversion estimate is 30 mmes to 1 milligram of buprenorphine. Anticipate withdrawal symptoms and try to get ahead of them using non-opioid medications. Make sure to hold short-acting opioids for at least 12 hours prior to starting buprenorphine when doing a standard rotation. Provide education and handouts for the patient to follow closely during the transition. And as always, use your motivational interviewing skills to prep patients for this change and get them on board with this therapy. Thank you.
This show has been brought to you through the generous support of the Centers of Medicare and Medicaid Services. Thanks for joining this week's Compass Opioid Stewardship in Practice. Thank you for being part of the Compass Opioid Stewardship Program, and thank you for all you do caring for your patients. See you next time.